Good afternoon, everyone. And today I shall be presenting an interesting case of haemorrhagic fever, which presented with bilateral eyelid ecchymosis and subconjunctival hemorrhage. A 17-year-old boy presented to us in the emergency department with complaints of redness in both eyes and vomiting. There was no history of trauma or any fall of foreign body in any of the eyes. Ocular examination showed bilateral eyelid ecchymosis in an arcuate fashion with subconjunctival hemorrhage, as you can see in the figure, and this was not associated with any kind of discharge. Visual acuity was 6/6 in both the eyes. Pupillary reactions, IOP and fundi were normal. A provisional diagnosis of idiopathic ocular hemorrhage was made, and the patient was treated conservatively with cold packs and topical naproxen eye drops. He was advised to come to the IOPD for review after 1 week. Analysis of the systemic presentation showed interesting sequence of events, as when the eye was examined on day 1, the general condition of the boy was fair with maintained vitals, and he was given supportive treatment of antiemetics, and a complete blood count was ordered by the physician. He was kept under observation in the emergency department for 24 hours. The next day he developed fever, became drowsy and disoriented with a pulse rate of 100 per minute and blood pressure of 90 by 56 millimeter of mercury. He was transferred to intensive care and given noradrenaline, antipyretics and volume replacement. CVC by the time was available, and it showed that he had a reduced platelet count of 11,000, suggestive of dengue hemorrhagic fever. Then he was transfused 1 unit of platelet concentrate. On day 3, he developed abdominal pain and had blood in his stools. A further unit of platelet concentrate and 1 unit of packed cells were transfused. Ultrasound showed gallbladder edema, a enlarged hypoic liver, and a free fluid in abdomen. By this time, dengue serology was positive. On treatment, the patient's condition improved, but his ocular findings persisted for a week. As we all know, classically dengue presents with fever, headache, retroorbital pain, nausea, vomiting, joint pains, and effects of thrombocytopenia. And the usual sequence of events is acute febrile stage of 2 to 7 days, which may or may not be followed by recovery. During defervescence, some develop dengue hemorrhagic fever, which may progress to dengue shock syndrome. And the risk factors for development of dengue hemorrhagic fever range from viral factors to individual factors and epidemiological factors. Dengue has wide spectrum of ocular manifestation, most common being blurring of vision, and the reason being dengue-related maculopathy. A central scotoma also is known, corresponding to the areas of edema and hemorrhage on the macula. Then subconjunctival hemorrhage is also quite common. Uveitis, optic neuropathy, and vitreous hemorrhage are very less common, and eyelid ecchymosis is extremely rare. Ophthalmic manifestations are rare as a presenting feature. Bilateral eyelid ecchymosis has not yet been described as a presenting feature of dengue. The present case is incongruous in the way that the systemic involvement at the type of presentation was not proportionate to the ocular findings. Further, eyelid and subconjunctival hemorrhages were present without any retinal hemorrhages. To conclude, bilateral eyelid ecchymosis as a presenting feature of dengue fever is rare and has not been previously reported. Trivial signs such as ecchymosis and subconjunctival hemorrhages are to be viewed with caution, and if these signs are present, then the patient should be investigated for systemic causes. Lastly, physicians also need to be made aware of such a clinical presentation to avoid wrong diagnosis. Thank you.
Thank you so much.